Hey, what's up, everybody? This is Corey Glenn, and if you're interested in learning how to take a patient that has terminal dentition and lots of problems with the smile and be able to place implants, immediate load them, design a restoration, and deliver that the very next day, then stick around. This is a video you'll want to watch. This is the patient we'll be covering on this video, and it's a case I recently completed with Dr. Danny Doming. He did all the surgical treatment. I did the digital planning on this, and we got an amazing result for a 24-hour turnaround. Very complex case, so stick around. Hopefully you'll get something out of it. Now, before we jump right into the case, I just wanted to mention a couple opportunities to learn. If you are interested in learning more about guided surgery, about implant treatment, digital planning, digital technology, there's a couple of opportunities coming up. So I'm going to be doing my comprehensive guided surgery course at my farm in Sewanee, Tennessee on January 26th and 7th. This is the course, if you've not done a whole lot with guided surgery or implants, this would be the one to start with. This is a great basic course for really anything leading into digital dentistry. We'll start assuming you know absolutely nothing. We'll cover the treatment planning aspects, some basics of implant placement, and then we'll do a lot of hands-on planning of cases from simple to complex. This course will cover all the tooth-borne guides as well as basic bone reduction guides, bone supported guides, and soft tissue full arch guides. And so this one's a great opportunity again. I love giving courses at my farm. Everybody usually has a great time there. It's not often that you get to go to a course and shoot guns during the breaks and ride around on ATVs and all that fun stuff. So I'd love to see you at that one. If you want to register for that, it's at coryglenn.org. And we do have pricing for lab techs and assistants, and then also for doctors. So hopefully you can join us for that. And then if you already may be doing guided surgery, maybe you're into full arch, we've got another opportunity in February. That'll be on the 9th and 10th in Houston, Texas. And that is the advanced full arch guided surgery course that I teach with Danny Doming, who I'm doing this case with. So this exact case would be more pertinent to this course. Very complex. FP1 on top, FP3 on the bottom, bone reduction, all of that stuff, photogrammetry, exocad design. I mean, this course really gets into the deep end. There's a ton of content that you take home and video tutorials, all that stuff, really for both courses. You'll go home with tons of content to reference back to. You really get a lot of bang for your buck out of these two courses. So if you're already into guided surgery, but you really want to step it up a notch, stackable guides, very complex cases, then this would be the next course I would suggest. And if you want to register for that one is at digitaldentalmasters.com, and we hope to see you at one of those. All right, so here's the patient as he initially presented for the case that I'm going to be covering today. So again, this was a patient Danny treated in his office, and patient showed up. He had a lot of failing dental work, lots of tooth problems, missing teeth, teeth that are breaking down. And as you can see here, we've got lots of discoloration, tons of cervical decay all over the place. Again, gaps in his smile. So lots of issues here. This is a challenging case, you know, right off the bat. And, just because you watch a YouTube video, don't go and attempt one of these. These really are extremely difficult cases, and there is so much that goes into planning one of these and executing it properly. And so again, this is where it's very valuable to attend a course and get a lot of the digital component from both myself and Danny, and then a lot of the surgical component from Danny, because I really don't know a better implant surgeon in the world than Danny Doming. So anyway, this is the patient as he originally presented to Danny's office. And as we take a look at the close-up pictures, you can see the teeth are just in bad shape. There's several teeth that are serviceable, but a lot of the strategic tooth positions we need, canines, things like that, are compromised. There's decay everywhere, high caries rate, and this patient honestly is just kind of done with it. He's ready to quit messing with these teeth and try to have something that will last him for the longer term period. So you can see lots of issues here. Here's the x-rays, because I know a lot of people always ask about that, are teeth savable? You can see these teeth are all extremely restored. And again, there is some teeth that are stable. This first molar, those are obviously okay. But when you start looking at the big picture, the patient's caries risk, his past dental history, plus his budget to continue redoing work over the coming years, it became evident that this patient was just not interested in trying to do any more with his existing teeth, and he wanted to go the route of doing something with implants. And so again, when I get these cases, Danny always does an amazing job of gathering all the necessary data to plan these properly. That's one of the things that you really can't stress enough. You need a bunch of pictures. You need the proper scans. You need intraoral scans taken at the proper VDO that you want to restore them in. Same way on the CT scan. Danny's going to get facial scans. There's so much data that Danny gives me that I've essentially got this patient digitized, and he sends it to me in Tennessee without ever seeing the patient, and we can do all of this detailed planning. All right, so the place I always start is smile design. It doesn't matter how complex the case is, I have the same paradigm every time I approach one of these cases. That is, I'm going to gather the data or have the data provided to me, and then I'm going to do some smile analysis, which is what you're seeing right here. And then once we do the smile analysis, we'll do a smile simulation to try and figure out our ideal endpoint. Based on the smile simulation, if the patient and the doctor approve of that, we'll take that into a 3D digital wax up, and then that wax up is what's going to dictate our implant planning. Prosthetic space, where the implants are going to emerge, the positions, the depth, all of that stuff. And then once we have implant positions, then we start tackling the guide fabrication. Once the guides are designed, they're fabricated, milled, printed, whatever you choose, and then you do the surgery. So a lot goes into all of that, but I'll try to break it down as simply as I can here. So what I'm always going to start with is I'll take this full face photo, and I've got a PowerPoint template. So this is my PowerPoint template that I've generated, and it's got pictures of my ugly mug, but the reason for this is it allows me to just right click on this, change picture, and I can sub in the patient's pictures for the case I'm working on. And so the idea here is that once you've got the picture in there, you would take this line and align it to the interpupillary line. And if the picture is a little canted, you just twist the picture until it's lined up. And then we're going to have a midline. Okay, so this one we're going to put right through the facial midline of the patient. And then these two lines I use as a reference for smile design when I'm trying to figure out where to put the canines. And so, from dentures, most people, the width of their nose is essentially the width of their canines typically. And so this is a picture of me, but this is actually not my teeth. Here's my teeth. So this was just an example of a smile design I did here. And so I'll also duplicate this line. I'll pull it down and use it as a reference. And so, when I'm looking at this, I can drag this line and know, okay, here's where I want to put the incisal edge with whatever kind of simulation and then ultimately wax up we're going to do. And all of this stuff becomes extremely useful when you're trying to plan one of these complex cases. I've also got all of these various tools in this. This is a golden proportions ruler. So once I have determined the width of the nose and the approximate width of the canines, I'll pull in this golden proportions ruler and then scale it so that this red line here is right on the canine and this red line here is on the canine, and then we're lined up on the midline. So when I start doing a simulation, this becomes a template that tells me exactly where to put the teeth. I'm going to drop the incisal edge on this green line where I think it needs to go. And then there's a lot of other cool tools in this, things to hide identities for patient presentations. And then one of the big keys to it is I've got a ton of smiles in the template here that I use for my simulations. Now you can buy all kinds of great smile simulation softwares. I've used many of them. I really like DTS Pro for kind of a ready-made solution, but you can also do this stuff in PowerPoint. And so what I try to do is whenever I see a nice smile online or from patients that we've treated, we try to get a nice retracted photo of those, and then that goes into my library. And now I can basically copy and paste these into that patient's smile, scale them, get them to the correct size and everything. And, that allows me to do a smile simulation just in PowerPoint. I've also got individual teeth here that you can sub in and scale. I've got all kinds of little PNG images that can be subbed in. Part of why I made this was for when you're doing treatment plan presentations. That's one of the big keys that is why Danny does so many of these big cases, because his patient presentations are incredible. He's got imagery, he's got past cases that he's done, he explains it on video and everything. And just having a lot of these things that you can sub in makes it very easy to do this. Here would be an example. Hey, for this patient, we need to place some implants, do a little sinus lift, place implants here, and then all these teeth in blue, those are the ones we're going to crown. There's just a bunch of cool little tools in here that we use on these things. And so that's actually something I sell on my website if you're interested in utilizing that. But with that said, let's jump back to our patient, and you'll see that's exactly what I'm doing. I've got my facial midline, I've got my inner pupillary line, which you can't see under the glasses to hide the identity, a duplicate of that placed to about where I want his incisal edge. If I zoom in here, you can see my golden proportions gauge, right? And so I learn a lot just from looking at this photo. For example, I noticed that his midline is about 1 millimeter off to his left, okay? And then I've got the width of the nose. That allows me to scale this to the canines. All right, so what I'm going to do then is, now that I've got all of this lined up, I'm going to go into my smile library, and I'm going to find one of those smiles that is, approximately shaped to what would work for this patient. So in this case, I grabbed this particular smile. You can see this is just something I snipped out of probably just an online picture somewhere. And I can drag and drop this onto the top of his face and then scale it up and down until my canines fall right to these lines. I've got the midline right here. And again, here is the particular smile that I've chosen for this patient. And one of the things I'll do, I don't know how easily you can see this in the video, but if you notice this smile curvature, I set that thing to align to the patient's lower lip, because generally you want the maxillary teeth to follow the lower lip. So with that, I can jump into my smile library. I'll just cut and paste that in here, because some of these are flat smiles. Some of them are really curved, right? Some of them are kind of in between. So if you notice here, I've taken that same little smile curvature and I've just superimposed it, and I tried to find a smile that approximated that curvature, because that's something I know will work in that patient's mouth. So I cut and pasted this particular smile, took it back over here, and I pasted it in. And again, now I just drag it over and scale it. Okay, so that is extremely helpful. However, one of the things you'll lack is that, this is just going to copy and paste over the top of this. And so sometimes it won't look natural. So one additional step that we can do here is that we can take this and turn it into a simulation. And the way that we're going to do that is that we're going to take his same facial photo, and I use a program called GIMP. It's like a free version of Photoshop, does all the same type of functions. And I love free. And all I'm going to do is select everything inside of the lips and then delete it. Okay. And what this does is it gives me a facial mask. So once I get to right here and I've positioned the teeth, I can drag and drop that over the top, and that's going to hide anything that would be underneath the lip. So you get a really natural looking smile design. All right, so here you see I'm dragging and dropping that over the top here, and that results in this really nice smile simulation. And so here for free, we basically have a really nice smile design, and this is going to be what helps dictate how I do my digital wax up. So this would be sent to Danny, or Danny would do this chair side. We would get a simulation we like, and then once we have that, we can go ahead and start doing our digital wax up. All right, so now, Danny's done his CT scans in the video that we want to restore at. He's captured intraoral scans, facial scans, all of that stuff, and he uploads it into a folder in the cloud, and I'm able to grab all that stuff and now start putting it all together in Blue Sky Plan. So here we are in Blue Sky Plan. You can see again the patient's teeth here, kind of the missing stuff. There's a bunch of root tips, just a lot of problems here. So I've stitched in all the models, and then I've also used the Blue Sky Bio automatic bone segmentation, which will segment the maxilla, the mandible, and all of the individual tooth roots. You can see here how we've got socket forms, we've got the individual tooth roots. All of this data is superimposed and stitched together really well. And so that's kind of the prerequisite for doing one of these cases. And then I'm going to take the facial scan that Danny provided me. So Danny's using the MetaSmile from Shining 3D, which is a great facial scanner. It's the one I'm currently recommending to most people. I've played with this. It's a great scanner. And you can get by without a facial scanner, but there are some things that it's extremely helpful on. For example, once you stitch this face into the rest of your data, now when you're doing your wax up, how on earth can you miss the midline, right? You've got the patient's face right there in front of you. And one thing I'll do additionally, and you don't have to do this, but I find it useful, is I'll generate these facial planes. So you can see this one's going to align to the interpupillary line. This is a duplicate of it, which I align from allotragus, because again, we know that that's going to be generally parallel to the occlusal plane. And then I'll duplicate that, pull it down, and that will be the occlusal plane that I'm setting teeth on or using as a reference to set the teeth on. Okay, so here's the facial scan. We've got everything integrated. We've generated our facial planes, and that's going to allow me now to do my digital wax up, and I can just turn the face off at this point because I've gotten all the data I need to see. And when I'm doing the wax up, I can just drop the teeth right on this plane and essentially align them to that. All right, so here it is after I've turned off the facial scan, and you can see that my wax up, I don't remember if I did this wax up in exocad or blue sky, but you can do it in either one, as well as 3Shape and a number of other softwares. But this is my full arch wax up that I designed for this patient. Based on that simulation that we did, I know where I need to set these teeth as far as incisal edge position, and then everything else is more or less aligning the occlusal plane of my wax up to the occlusal plane of this. And so this is going to be the maxillary wax up that helps dictate where implants are going to go. And this is going to be what ultimately, after Danny places implants, is going to get converted and built into his immediate load restoration. All right, so turning those facial planes off, you can see here, this is my wax up. Now this is going to be for an FP1 on the top, and I really try to take a lot of care to actually pull my cervical portions of the teeth where they're emerging right out of existing sockets, if there are any. That's going to make this a lot easier to fit in that patient's mouth once implants are placed. Now, in this case, I didn't do a lower wax up because, frankly, from an aesthetic standpoint, it's not contributing that much. And secondly, I can look at the maxillary wax up and know how much space I've got and where I need to put the mandibular implants. I essentially would ideally like to emerge with my implants right against the lingual functional cusp of those maxillary teeth. So didn't do a lower wax up here, and that's why. And here you can see my wax up kind of turned to 50% transparent where you can see his existing teeth underneath it, right? So this is, where I'm going to shoot to move the teeth to. And this was the final treatment plan that we came up with. So based on that wax up, which Danny now has and is stitched, we place the implants. I always get whoever the treating doctor is here to verify the implant positions. If they want to make changes, they can do that. But the plan here is that we're going to put in 2 pterygoid implants, and then we'll do uh, second premolars and then canine sides. And again, this is going to be for an FP1 in the maxilla and then an FP3 on the mandible. And more, that seems to be the route that we're going. So often when you have these terminal dentition cases, it's such a shame to just remove all of that bone in the maxilla. If you can do an FP1, that needs to be your default. Now, the challenge is that FP1s are so much more technically difficult to accomplish and do a good job at, especially if you've got issues like high smile lines and things like that. I've actually got another case that I'm working to present where we, in fact, had that really excess maxilla, and man, that one was extremely difficult. So don't jump into this half-heartedly. You've got to do a lot of planning on this. Consider gingival margins, all of that kind of stuff, gingival display. But more and more, we seem to be doing FP1 in the maxilla, And then the mandible, oftentimes, again, with these terminal dentition cases, they seem to have super erupted anterior teeth. And so there's excess bone. And so oftentimes, you can see these implants right here are essentially at the crest. And then due to some super eruption in the anterior, these front implants need to go a little deeper. And so typically, I would say, the majority of our treatment plans, we're doing FP1 in the maxilla when it's possible. And then the bottom, it's easier generally to do an FP3, and you don't have to worry quite as much about gingival levels and all that. You can get more or less a flat plane of reduction, place your implants, and then the FP3 tends to work really good on the mandible. All right, so let's look at the implant positions as Danny approved them. Here we've got canines, premolars, and then the pterygoid implants are going to emerge right inside of the second molars. So we're always shooting to emerge, when possible, lingual to the incisal edges. And then in the posteriors, we're trying to emerge through the occlusal table somewhere. And, Danny's going to end up restoring this and milling an immediate load restoration, which he'll use his vortex screw on. If you're not familiar with that, go to Danny's lab website, which is Louisiana Dental Implant Lab, and check out his vortex screw. There's a lot of really neat advantages to that. And I won't go into all of them, but you owe it to yourself to go look into it. It's an awesome screw. A lot of people are switching to that now. But one of the cool things with this is that, let's say the bone dictated that you had to emerge through the incisal edge, that screw gives you some angle correction with it. And so you can build that into your case as you're designing the final restoration. All right, here's the emergence positions looking from the facial. And here's the implant positions as they relate to his current dentition. So if you did your planning just looking at his existing dentition, that may not be where you would put, for example, these two implants, right? They're coming out in the incisal edges, and if you were trying to do screw retain, you would be worried about that. So you might end up positioning those a good bit more lingual. But again, based on the new wax up of what we're trying to get him to, that puts us perfectly in the cingulum area. That's where we want to be. So the takeaway from that is, don't plan based on the existing dentition. Do your planning based on where you're trying to get to. Start from the end and work backwards from that. That's the number one takeaway I would say to get from this presentation. All right, so with the teeth gone, this is what the implant positions are going to look like. And so now we've planned our implants. We're going to go FP3 on the bottom, FP1 on the top. Now, one of the things you need to consider before you just jump into this, and why these are so complex and have to be thought out, if we just simply numbed the patient up, extracted all of his teeth, placed those 6 implants, well, now we've got to capture a scan of this data. Remember, Danny's going to deliver a next day restoration. He could do it same day, but he's going to do it next day. But if you just placed your implants and, for example, all the teeth are gone, and now you place 6 scan bodies and you take a scan, first of all, that scan is going to suck. It's going to be a huge bloody field. The gingiva is all displaced. Even the palatal tissue, which is still going to be in place, is going to be extremely swollen. And so what you would miss is you would lose all of your stitching data. There's no way to get this scan, once you've scanned it with the implants in place, stitched back to all your original data. And that's extremely important because, remember, we've already got the wax up and everything done. What we want to do is just build in the implant connections to that wax up. But if we can't stitch the data, you're kind of dead in the water. And so think about this from a perspective of how you would tackle the case. Now, one other thing I'll mention is Danny's doing an entirely digital workflow, which means he's not pouring cast and taking impressions. He's doing this all with intraoral scans, and then he's also using photogrammetry. So Danny's got an iMetric unit, and photogrammetry is going to allow you to take a scan, and it's going to be a dead-on perfect scan of just the implant positions. It doesn't pick up bone or tissue or anything like that. And it essentially corrects the data in your intraoral scan. But now again, how do I get all this data meshed together and stitched together properly? And the answer is, it's extremely difficult. Sometimes you can get away with it using palatal tissue anatomy to stitch to, but oftentimes that's even so distorted that everything gets off. And the mandible's even worse because there is no palate, it's all tongue, which is mobile tissue. So one of the ways that we tackle this, and it's not the only way, but it's one that's worked very well for us, is to consider placing one or two implants in the very back first. And for that, we can just use a simple tooth-borne guide and then leave all of the other teeth in place. So let's imagine here, we place those two pterygoid implants, we put the scan bodies on, and we go ahead and take an intraoral scan. So that intraoral scan has all of these other teeth, the palatal tissue, everything like that before it's all distorted, but it's also going to have the two scan bodies in those second molar areas, okay? And then he can go ahead, extract all the rest of the teeth, do any reshaping of the bone, place his other four implants, and now do another scan. So you've got three scans here. The intermediate one with the pterygoid implants stitches perfectly to the intraoral scan because it's got all of those common teeth. And then your final scan, which now just has six scan bodies, and there would be no way to stitch to that. But what's going to be the common data between those two? It's going to be these two implants, which were previously placed already. So now you've got these layers, and you're getting all of your data stitched properly back together so that it's going to be easy to convert that digital wax up. So if we're going to tackle it that way, then what we'll need to do is generate a tooth-supported guide that is just for placing those pterygoid implants first. All right. So all I've done here is I've opened up his intraoral scan in Mesh Mixer. I've selected these two teeth, and then I just delete those teeth and kind of make them into an ovate Pontic site. I'm just really trying to get them out of the way so that now I've got a model I can just build a tooth-supported guide on. All right, and then here is that guide. All I've done is turn on the two pterygoid guide tubes, and we've generated a tooth-supported guide. You can see it's got windows and all of that fun stuff. So this will be guide number 1 in the maxilla, and we're going to take a similar approach in the mandible. I should also mention one other alternative that you'll sometimes see Danny and others doing is placing a big palatal scan reference right here. So this would screw into the palate, and that becomes something that doesn't change. You can do an intraoral scan pre-op with that in place, and then once the teeth are gone and now all you have is scan bodies and distorted tissue, that becomes your common data that you can stitch to. But we really like this method a lot as well because in the mandible, the one I was mentioning just now doesn't work that well, right? You don't have a palate to screw something into. And so it can be very difficult to get all your video and everything done correctly. All right, and here you see that guide in place. So Danny just extracted the second molars, and now this guide goes in place. And this is just for a pilot guide. Danny's going to generally just do a pilot hole to get his depth and trajectory set for those pterygoids, and then he'll freehand it up from there and then drive those into the pterygoid plates. And then I don't have a picture of the scan once those are in place, but once he does put those implants in, he's going to place his two scan bodies and stop and do an intraoral scan, capturing all of these teeth and those two scan bodies. That's a critical step because that model is going to be the bridge between your pre-op data and your final scan with no teeth and all the implants present. And then once he's done that, now I'm going to generate him a second guide, and this guide is just going to be for placing the anterior four implants. And so this one, I just opted to do a simple bone-supported guide. With the teeth being present, a lot of times it's difficult to make out what's bone versus what's tooth right at the crest. So one way I avoid that is I just, I've got the roots from my segmentation and blue sky plan. I can just design a guide on the bone and then subtract my roots from it. And that now gives me these passive openings here where he'll be able to see his sockets. It helps with his alignment and keeping reference of where everything is. But also it's going to keep him from having as much interferences as he tries to seat this guide. Now this is a pretty low profile guide. It's kind of thick because he's going to print this one. If you went metal, you could go significantly thinner, and that's the case I'm going to share next. After this video is one where we did a metal guide, and that's even nicer because it will really slide under your flaps easily. But even this is low profile. It does not have to go far down the facial or the palatal. In fact, even after this is printed, you could probably do some additional trimming to really thin out these edges where it'll slide under your flap. But we're just going to flap enough to get this guide seated directly on the bone, and it's essentially resting on the interproximal bone occlusally. And with this guide in place, Danny will go ahead and do his guided osteotomies for these 4 implants. All right, that's a facial view of it. This is designed to be fixated with little bone fixation screws. You could also use the Blue Sky fixation pins or some other brand of pins, but I really like on dentate cases to use those tiny screws because a lot of the fixation pins can be a little bit too big in diameter, and when you've got 6 implants to work around, plus all of these teeth that were present, that doesn't leave a lot of bone to grab with your pins. So with these little bone fixation screws, I can grab every little piece of interproximal bone, and you can see I got 5 screws in here with no problem whatsoever. So jump into the surgical portion of this. After he placed these 2 implants, and you can see these are those scan reference markers that he took his intraoral scan prior to extracting these teeth, and those have been left in place because they're going to get picked up in the next scan as well. But now he just reflects the palatal and buccal tissue just enough to get this guide seated and makes really nice and sure that it's completely seated on the bone, and then that gets pinned into place. All right. So now he does his osteotomies for these 4 implants. Here's the guided drills in place. Another shot of that. And now here is the final result, which has all 6 implants in place. And again, I want you to think back, if you just skipped all those steps that I just talked about and you had your pre-op and now you just extract all the teeth, you place these scan bodies. Sure, you can get a scan with your intraoral scanner of this. It's not going to be the greatest quality, but the bigger question is, how do I stitch that back to my preoperative data? I don't know how well you can remember, but if you looked at the palatal tissue in his pre-op scan, very defined rugae and everything, look how swollen and edematous this is. All of that anatomy has been altered, so you're going to really struggle to get a good stitch, and it's probably going to be off in some capacity. But since he has that intermediate scan where these 2 scan bodies are present in both of them, that's going to allow him to first stitch the scan of just these 2 back to the pre-op, and then with that common data, you'll stitch this scan to the intermediate one. All right, so that's the maxillary surgery. He got all that data, and as soon as Danny's taken those scans, he can actually hand that data off to his lab, and his lab begins designing that restoration. All the data gets pulled in and stitched back to this, and then they can just take that upper wax up that we had done and build in the implant interfaces. All right, because it's photogrammetry data, it's incredibly accurate on the implant positions. So now let's look at the mandible. The mandible, as I mentioned, we're going to do an FP3 here. And so if I'm doing an FP3, I typically want to make sure that we've got about 15 millimeters of restorative space. And so his mandibular teeth in the premolar region were roughly in the right position. So if I measure backwards from the tooth to apical down to 15 millimeters, that more or less gives me a plane that I can plan to. And so I actually generate a plane, an STL, which I bring into the case, and I position it such that it is 15 millimeters down, and then all of my implants can get placed referencing that. So as we're placing this implant, we can look and see, okay, right there is the minimum depth to give us that 15 millimeters of restorative space. And then Danny likes to go pretty deep with his implants. He'll typically go 2 millimeters subcrestal with his implants, and then he'll use a taller multi-unit abutment that stays skinny, and then once it's up and out of the bone, it'll emerge out, and that gives us really good results. So this plane that I've imported, I'm going to use it for 2 purposes. I'm going to use it as my reference as we're planning these implants. I've got to get my depth below this by however much subcrestal Danny wants them. But then also that same plane is going to get used to be it's going to be what creates my reduction guide. All right, so you can see here how this plane has been oriented off the occlusal plane, and then it just tapers up here at the back. My implants have been placed relative to that plane, And now what I can do is I can just generate a guide directly on this bone. Now this first guide, I won't have any guide tubes or anything. It's just almost like making a night guard on the bone. So we generate that. And then, oh, I forgot about this. We're also going to tackle the mandibular arch in the same way. If you notice these mandibular implants, they were essentially right at the crest. So it makes sense to just extract the teeth that are in their way. Use this tooth-supported guide to place the back tooth, and now you can do a scan with scan bodies on just these two implants and the teeth still present. That becomes that intermediate scan that I was talking about. And then once you've done that, now you can go ahead, extract the remaining teeth, and now we'll look at the bone reduction guide. So we had a significant amount of bone to reduce in the anterior. It's just another view of that tooth-supported guide. So here you can see this is that plane again, and you can see the existing bone above that. So I have a general rule that if the bone is standing up higher than about 4 to 5 millimeters above where your implant platform needs to be, for me that needs to be a bone reduction guide. So again, I'll start by just making a guide directly on this bone, but once I have that, if I will take this plane, this green plane right here, and subtract it from that guide, what it gives me is a bone reduction guide. You see this? And if I take that same plane and I subtract it from his mandible, that gives me a model of what the jaw will look like after we do that amount of reduction. All right? So here's that reduced jaw. And here is the reduction guide. All right, so Danny, after he's placed those back two, he'll go ahead and extract all the remaining teeth, seat this over the mandible like so, and then he's just going to lower the bone down to the level of these flats. Now we do these all different ways. Sometimes we'll do buccal only, sometimes metal, sometimes printed. There's no right or wrong to that. It's kind of situationally dependent. Here we chose to go with a little bit of a lingual bar. One downside to doing a buccal only guide, while it's great and it's less invasive, oftentimes you can end up with a cant to your burr and you might have like an uphill plane of reduction. Whereas when you actually have a little lingual strut, even if it's extremely thin, let's say that was 1 millimeter thick, it gives you a target of where that plane of reduction should be. So I need it level to the guide here and on the lingual. And having that slight lingual bar makes it a lot easier to get a very accurate plane of reduction compared to just a buccal only reduction guide. All right, so we opted here since we were kind of behind the gun on time. We didn't have time to get a metal guide 3D printed, so I made this a little thicker. It's 3 millimeters thick, whereas a metal reduction guide I might make as thin as 1.5. But once I have this, we're going to do a swappable guide on the mandible. All right, so there's stackable guides, right, where you would just fixate this and then leave it in place. And once it's reduced, you could stack a drilling guide on top of that. And that's nice. It doesn't require you to swap anything out. It for sure is more effort in the planning phase. It's going to require a lot more software skill. One of these guides is a lot easier to generate. So this is the drill guide. So he would use this one, do his bone reduction, and then once he's done that reduction, unscrew it, he can take that off and throw it in the trash. And now he can seat the drilling guide. So as I toggle back and forth between the reduction guide, the drill guide, the reduction guide, the drill guide, what I'm trying to show you is, do you notice the similarities between these two? Reduction guide, drill guide. They are actually one and the same. I don't generate an entirely new guide for the drilling. Rather, all I'm doing is I'm taking that existing reduction guide and I'm building the guide tubes into it. Okay, so this is all the exact same reduction guide that we just had. And that has a lot of value because how do you know if you've completely seated this one? You are swapping things midstream here. How do you know if you've completely seated it? Well, your pinholes ought to exactly align. So if your pin's not going into the same place as the last guide, you know this one's not properly seated. All right. The nice thing here, you're getting a trade-off. It's a trade-off in that this is a little bit more time or effort or whatever in the surgery because you do have to take off the first and then seat this one. But the benefit is that this is far easier to design. Uh, yeah, guaranteed, I can have you designing these in that level 1 course by the end of it. To do the stackable guides is a pretty significant step up in difficulty, and it's going to take a lot more effort to get to that point. But this is something anyone can do. And if you've simply got a 3D printer in the office, you can 3D print these things. They are going to be weaker than a metal guide, but I mean, each of these costs you 10 cents to print. You could print 4 of them, and if one breaks or something, take it out, throw it away, put in one of your backups, okay? So I do try to make these pretty stout. You can see all I've done is I've exported the tubes, then I've connected each tube one to another to give it a lot of rigidity. I don't need to do those back implants. They're already in place. This is just for the 4 anteriors. And then I try to put a pretty big beefy tube that connects those floating guide tubes down to the original reduction guide. And now that just becomes my drilling guide. So I'm really only designing the reduction guide and then I'm just adding tubes to it. That's the swappable guide system the way I typically approach it. All right, so here's the mandibular surgery. Danny's going to initially just extract any teeth that were in the sites of those posterior implants, the first molar area. And once he does that, I do that in the same way I did on the maxilla. I just select those teeth, delete them, make it an ovate ponic site, and now that's a guide I'll build, or that's a model that I'll build this guide on. So he's going to just now do a tooth-supported guided surgery for those 2 implants. Lots of windows here. Those are critical because you need to be able to look in here and verify that this is 100% seated. All right, if it's not, that throws everything off. So having these windows, that lets me see there's no gap between the underside of this guide and the top of that tooth. All right, and that should be the case in all of these windows. So Danny placed those implants. Again, we're missing a few pictures here just because it's a challenge to photograph every single step of a case like this. But he went ahead, placed these 2 implants, left these teeth in place, put his scan bodies on, and did his intermediate scan. Right, that's going to be the bridge between the final scan where all the teeth are gone and the preoperative data. So he's done that. You can actually see here's those scan bodies in place. And now he can flap a little bit more aggressively and he's going to seat that bone reduction guide. And so you can see this is a very intimate fit here. You only have to reflect just enough to get this thing seated. And I think this is 3 millimeters tall vertically in height. That's one trade-off to doing printed versus metal. Again, is you're going to have a little bit thicker guide and a little bit taller guide just to have enough rigidity where this isn't going to break real easily. So now he's going to go in here with his burr and he's going to lower the bone right to the level of this flat on the reduction guide. All right, here's a facial view where you can really see that much more. Again, my general rule, if there's more than about 4 to 5 millimeters above where I need the bone reduced to, I think you're better off to do a bone reduction guide. And so here, that's probably 8 or 10 millimeters, I would guess. So now he's going to flatten everything down to that level. And here you see following bone reduction. All right, and again, that lingual gives you a nice target so that you get a very smooth, flat plane of reduction. So at this point, the bone reduction guide has done its job, and we can just simply unpin this, throw it in the garbage, it's done its thing. Now we're ready to put on the drill guide. And so here's the drill guide. Again, it's the exact same guide. These tubes are floating up off the bone, so they're not going to affect the fit at all. It should fit just like the previous one. So when those pinhole or screw holes line up and go into place, you know that that's seated and you're in the right position. You just need to make sure when you're trying to seat these that you're not letting tissue get caught up under this guide where it's difficult to get this thing seated or it might inhibit it from seating altogether. Again, note the scan bodies from the implants that were already previously placed. So now Danny's going to make his osteotomies using the keyless drills. He's going to place these implants, and there's the money shot. You can see the drill at full depth, and now you can see the implant in place, you know, that 2 millimeters down below where the level of bone reduction was. That's the money shot that you're looking for. And just another little close-up here. And of course, you can see a little buccal gap here. You're going to have gaps around all of these implants in places that you'll have to graft. I'm just not covering all that stuff necessarily. And just one more occlusal view, just dead on the money. It's very difficult to get off in this scenario if you do it right. If you think this thing through and you approach it properly and you make sure your guides are seated, this really should make for an extremely safe and an extremely accurate surgery. And that's going to mean a better result for your patient as far as their prosthetic. Because again, I always say this, but ultimately your patient doesn't care about your implants. They care about the teeth. All right, the implants are our job, and it's just the step that enables them to get some teeth there. And so here is the final of that. And again, you can imagine if we just had this scan, how would you get it stitched back to the pre-op? You really couldn't. So we've got that bridge. And so Danny takes all of that data. Because we had those intermediate scans, he pulls them back into the preoperative orientation. He has his implant positions, and now he simply goes into exocad and converts the original wax ups that we had into immediate load restorations. Um, I'm not entirely sure if Danny printed the immediate load or if he milled it. I think a lot of times he'll print this and just go direct to the multi-unit. I think that's what he did, but he might have milled a PMMA. PMMA is going to look a little bit nicer and be slightly stronger, but printing is just so easy to do. And if you don't have tie base inserts and all that kind of stuff weakening it, we've seen that those printed restorations can hold up very well also. And so this is the immediate load restorations, upper FP1, lower, excuse me, lower FP3, and this is 24 hours later. This is the next morning after doing that surgery. And to be able to give a patient a smile like this right after a significant surgery like that is an absolute life-changing treatment. Okay, he just did an awesome job. You can see the midline was nailed. There might be the slightest of a cant here, but remember these are temps, and so we can always alter that in finals. And that's one of the benefit to having some provisionals is that it lets you really dial that in and be critical so that when you get to the final, you don't have as much guesswork. You've already got this as a reference, and so if we wanted to fix that cant, we can just slightly tip the teeth a little bit and everything's going to be good and we know it's going to look great. All right, there's the patient smiling close up, and here's the retracted. Again, remember, this is 24 hours post-surgery, so the tissue is going to look a little beat up here. All of this will fill in because the tissue follows the bone. We have interproximal bone peaks and everything. That was all in there by design. And then on the lower, of course, this is just painted on gingiva on the printed restoration. So it's a little difficult to see down here the surgical side. But same thing there. The tissue is going to look a little ugly. That's going to all fill in and look amazing. And because we've got these perfect ideal provisionals, the tissue is going to heal to that. So in 3 to 4 months, when Danny's ready to restore this finally, he's going to have amazing tissue to build that final too. It's going to look like these things are emerging right out of his gingiva like natural teeth. And that's always the biggest challenge with an FP1. So hopefully you got something out of that. Again, would love to see you at one of these courses. Again, we've got the comprehensive guided surgery course coming up. Again, that would be the starting place. If you're not doing tons of full arches or if you're just new to guided surgery, this would be the course to start with. Go to coryglenn.org, click on guided surgery courses, and here you see comprehensive guided surgery. And then I do also have a online version for purchase of the advanced course. Now, this was just me. This didn't have Danny in it, but this was the recording of the full arch design course I gave in Australia earlier this year. And so that's available for purchase online that teaches stackable and all that stuff. But then if you also want to do this in person, then go to digitaldentalmasters.com. This is me and Danny's joint website, and if you go to in-person courses, advanced full arch guided surgery, you'll see here this is the Houston course, February 9th and 10th. It's got all the information, 20 hours of CE, 25 plus hours of tutorials, all the information's there. So we'd love to see you at one of those two, and we also are doing a live online version of this course. So if you can't make it in person, but you'd like to take it live, we're going to be offering that through Zoom. And so that's certainly an option if you want to do it. And we've also got, for this course, we have a pretty big facility, so we're actually making it relatively cheap to bring assistants or auxiliaries if you want, because when you get into this complex stuff, that is team dentistry. That's not something you can manage just on your own. So bring some teammates with you, lead assistants, lab techs, whatever, and get them involved in this so that you can really dial in this workflow. And with that, I'll shut up, but hopefully you got something out of this. All right, thanks.